Welcome to this deep dive. We're really glad you're joining us today.
Yeah, thanks for having me. It's a great topic today.
It really is. Now, I want you to just imagine looking in the mirror. When you look at your own face, you probably just see your eye, right?
Right, just the surface.
Exactly. It looks like a single, relatively simple organ staring back at you. You have the white part, the colored part, the pupil. But what if I told you that to a medical detective, the human eye and the socket it sits in?
The orbit.
Yes, the orbit. It isn't just one solid thing. It's actually a highly complex piece of real estate, intricately divided into very specific, distinct neighborhoods.
It's a completely different way to look at human anatomy, honestly.
Mm-hmm.
We usually tend to think of the body in terms of these broad, overlapping systems, like the nervous system or the circulatory system.
Right.
But the microgeography of the orbit is incredibly rigidly structured. The borders matter.
And those borders, those structures, are exactly what we are exploring today. We're pulling our insights from a brilliant, really comprehensive radiological guide. It's titled Practical Approach to Orbital Lesions by Anatomic Compartments.
It's a fantastic source.
It is. And our mission for this deep dive is to decode exactly how radiologists use the specific geography of the eye socket to solve some of the most complex medical mysteries out there.
Because it really is like a mystery.
Okay, let's unpack this, because to me, reading through this source felt like a completely revolutionary way to think about diagnosis. Why does the physical location of a problem matter more than almost anything else when we're talking about eye conditions?
Well, traditionally, medical professionals might approach a differential diagnosis based purely on the category of the disease.
Yeah.
They might ask, is this a tumor? Is it an infection? Is it some sort of generalized inflammation?
Sort of casting a wide net.
Exactly. But this source material advocates for flipping that process entirely. Radiologists segment the orbit into highly specific spaces, the intraconal, the conal, the extraconal compartments, along with the globe itself and the optic nerve.
So breaking it down into those neighborhoods.
Right. The fundamental premise here is that certain diseases have incredibly strict zip codes.
Zip codes, I love that.
Yeah. By simply identifying which anatomical compartment a lesion is located in, a radiologist can drastically narrow down what that lesion actually is, often without even needing a physical biopsy right away.
Which is huge for the patient.
It's massive. It takes an overwhelming, endless list of medical possibilities and turns it into a highly solvable puzzle just by looking at the map.
I really love that concept. It's almost like knowing that if you're looking for a specific type of heavy machinery, you go to the industrial park, not the residential suburb.
Exactly. The location does half the work for you.
So let's start our tour in what I like to call the core hardware. We are talking about the optic nerve sheath complex, or the ONSC, and the globe itself.
The main structures.
Right. And reading through the source, the best way I could visualize the optic nerve was to think of it as the main heavy-duty cable connecting a camera,
Which is your eye.
to the computer processing the image, which is your brain.
That cable analogy works perfectly, especially when you consider how it's built. Just like a high-tech underground cable, it has an outer protective sheath, and it has the inner wiring that actually transmits the data.
And it's connected directly to the brain, right?
Yes, this entire complex is actually a direct physical extension of your central nervous system. Because of that unique anatomy, the diseases that affect it are very specific.
Like optic neuritis.
Exactly. Take optic neuritis, for example. This is an inflammation of the optic nerve that causes sudden, painful vision loss.
And the source specifically highlights a strong connection between that inflammation and multiple sclerosis.
It does.
But how does a doctor know it's MS just from looking at a scan of the eye? I mean, it's just a picture.
Well, when a radiologist looks at an MRI of a patient with suspected MS-related optic neuritis, they're looking for a very specific geographical signature along that cable.
What does it look like?
Typically, the inflammation is unilateral, meaning it's only affecting one eye, not both. And crucially, the inflamed area usually covers less than 50% of the total length of the nerve.
Oh, okay, so it's not the whole nerve.
Right, it's a short, localized segment of inflammation. If a radiologist sees that specific short pattern on one side, multiple sclerosis becomes a primary suspect.
Wow.
But we have to contrast that physical footprint with another condition called ischemic optic neuropathy, or ION-N.
I saw that in the notes. Is ion basically what happens when the blood supply to the nerve gets cut off, like a stroke?
That is the perfect way to describe it. It's a vascular issue, a blockage of blood flow rather than a primary disease of the nerve coating like MS.
So how does that look different on the scan?
On an MRI, An ION stroke looks completely different from inflammation. Because the tissue is actually being starved of oxygen and it's starting to die, the water molecules inside the cells get trapped.
Trapped water.
Yeah. On a specialized MRI scan, this trapping of water shows up as something called restricted diffusion.
Restricted diffusion. Got it.
On top of that, the swelling from the stroke can cause the head of the nerve to light up intensely when contrast dye is used. Radiologists actually call this the bright spot sign.
The bright spot sign.
You see that bright spot combined with the trapped water molecules, and you know you are dealing with a stroke of the nerve, not MS.
It's amazing how a single static picture can tell such a specific, dynamic story if you just know the language.
It really is.
And speaking of the pictures, the source describes this one visual pattern for tumors on that cable that I thought was fascinating. They call it the tram track sign. What exactly does that look like?
That is a classic visual for a specific type of benign tumor called a meningioma. These tumors don't grow inside the nerve wiring. They grow from the meninges.
Which is that protective outer sheath we talked about earlier.
Exactly.
So because it grows on the sheath and not the nerve itself, when they inject the contrast dye for the MRI, the tumor lights up on the outside, but the actual nerve running down the middle stays dark.
You've got it. It visually creates two glowing, parallel lines running down the eye socket, with a dark stripe in the middle.
Literally like train tracks.
It literally looks like train tracks.
Yeah.
And again, it perfectly illustrates the power of spatial diagnosis. The tumor is in the sheath, not the nerve tissue itself.
Right.
That spatial fact completely differentiates it from something like an optic nerve glioma.
Which is different how?
An optic nerve glioma is a tumor that expands the actual inner wiring of the nerve itself.
Oh, I see. So the middle part would be glowing instead.
Exactly.
Let's follow that cable straight into the camera itself, the globe of the eye. The source dives into two major conditions here that are quite serious, but from a purely diagnostic perspective, they leave incredible clues. First is retinoblastoma.
A very important one to discuss.
I saw the term leukocoria associated with this. What does that mean in plain English?
So retinoblastoma is a type of pediatric cancer. It's the most common intraocular malignancy in children. Leukocoria translates roughly to a white reflection in the pupil.
Like when you take a photo with a flash.
Yes. You might have seen old photos where a camera flash causes a red eye effect. In a child with a retinoblastoma, that flash reflection in the pupil glows solid white instead.
That is terrifying.
It is, but it's often the very first clinical sign that parents or pediatricians notice.
And when that child gets an MRI, what is the radiologist looking for inside the globe?
They're looking for a very specific footprint left behind by the tumor. Retinoblastomas are notorious for calcifying. They build up tiny deposits of calcium.
And how does calcium show up?
Well, on specific, highly sensitive MRI settings, calcium doesn't light up. It actually creates these dark, empty-looking voids.
Like black holes.
It looks almost like tiny black holes scattered within the mass inside the eye. The presence of those dark calcium holes is a major diagnostic indicator.
The second globe condition the source covers is uveal melanoma, which affects adults. Now, when I hear melanoma, I immediately think of skin cancer. How does that relate to the inside of the eye?
The uveal tract, which is the layer inside your eye that includes the iris, is incredibly rich in melanin. That's the exact same pigment that gives our skin and our eyes their color.
Okay, that makes sense.
And what's fascinating here is that melanin actually has a paramagnetic effect.
Paramagnetic. You might need to break that down for us. Does that mean it's magnetic?
In a subtle way, yes. It means the melanin interacts with the magnetic field of the MRI machine in a very unique, natural way. It acts almost like a built-in contrast dye.
Wait, really?
Yeah. Usually to make a tumor light up on an MRI, a patient has to be injected with a chemical contrast agent. But even without injecting the patient with anything, a highly pigmented uveal melanoma will show up uniquely bright on a standard T1-weighted MRI scan.
Without any dye at all?
None at all. Most other tumors or fluids look dark on this specific scan setting. But melanin shines brightly all on its own. It's a built-in beacon telling the radiologist exactly what the tumor is made of.
That is just incredible biology right there. The body is essentially highlighting the problem for the doctor.
It really is.
Now, before we leave the globe itself, I want to ask about detachments. The source mentions retinal detachments and choroidal detachments. To a layperson, both of those just sound like the inside wallpaper of the eye peeling off.
That's a good way to picture it.
But anatomically, they create totally different shapes on a scan, right?
They do. And it all comes down to where those internal layers are naturally glued down. The
What was the inner layer that processes light.
Right. It's firmly attached at two specific rigid anchor points, right at the back of the eye where the optic nerve connects, and at a ring near the very front edge of the eye called the ora serrata.
Okay, so front and back.
So if fluid gets behind the retina and starts pushing it off the wall, it can only peel away between those two solid anchor points. It stays tethered at the front and the back. On a scan, this peeling creates a very distinct V shape.
Because the top and bottom of the V are those anchor points holding on for dear life.
That's it exactly. But the layer right beneath the retina,
The core layer.
which holds all the blood vessels, that isn't anchored in the same rigid way. When the choroid layer detaches due to fluid buildup, it just bulges heavily inward from the sides.
So no V shape.
No. Instead of a tight V shape, a choroidal detachment bulges out and looks thick and curved. The source describes it beautifully. It looks like a biconvex round tennis ball sitting inside the eye.
A V shape versus a tennis ball. It's almost like the body is leaving giant visual clues if you just know what you're looking at.
Diagnostic cartography.
All right, let's step out of the camera itself and move into our next neighborhood, the conal space. I visualize this as the muscular engine room of the eye. It's what actually moves the camera around.
The conal space is entirely defined by your extraocular muscles. Those are the specialized muscles that pull the eye to let you look up, down, left, and right.
Okay.
These muscles form a cone shape around the optic nerve, and they all converge at the very back of the eye socket into a tight, fibrous ring called the annulus of Zinn. Think of it like the gathered end of a bouquet of flowers where all the stems are tied together.
Here's where it gets really interesting, especially when things go wrong in this engine room. The source goes deep into something called thyroid eye disease, or TED. This is an autoimmune condition often linked to Graves' disease, right?
Yes, and it completely wreaks havoc on these specific engine room muscles. But the key for radiologists is that it doesn't do it randomly. TED has a very strict, highly predictable order of operations.
Meaning it hits certain muscles first.
Exactly. It affects multiple muscles, but always in a characteristic sequence. Radiologists actually use a mnemonic to remember which muscles swell up first. It's IMS low.
IMS low. So IMSLO. Why does the order matter so much?
It stands for the exact order the muscles are targeted by the immune system. The inferior rectus muscle at the bottom swells first, then the medial rectus on the inside.
And then superior on top.
You got it. Then the lateral rectus on the outside, and finally the oblique muscles. IMS low.
So if a scan shows just a few of them swollen.
Right. If a radiologist looks at a scan and sees the bottom, and inside muscles are swollen, but the outside muscle is perfectly fine, thyroid eye disease is immediately at the top of their list. The pattern confirms the disease.
But it's not just which muscles are swollen, right? It's how they swell that creates my absolute favorite visual from the entire source text. They call it the Coca-Cola bottle sign.
Yes. When TED attacks a muscle, it causes the main fleshy body of the muscle, the belly, to swell up heavily with fluid and inflammation. But crucially, it completely spares the tendons at the ends.
The parts connected to the bone.
Right, those stay thin and normal.
So you have this thin tendon at the top, a massively fat, swollen muscle belly in the middle, and then another thin tendon at the bottom. It forms the exact curved, contoured shape of a classic vintage glass Coca-Cola bottle.
And if the shape isn't just a fun piece of medical trivia, it is the vital, deciding clue that separates thyroid eye disease from another nasty condition called idiopathic orbital myositis.
Wait, so how does myositis look different? Isn't that also just an inflamed eye muscle?
It is an inflammation of the eye muscles, yes. But the geographical difference is that myositis involves the tendons.
Oh.
The inflammation doesn't magically stop at the muscle belly. The swelling travels all the way down the tendon and attaches to the bone.
Oh, wow. So because the tendon is swollen too, it doesn't look like a Coke bottle anymore. It just looks like a thick, swollen tube all the way down.
Exactly.
So just a fraction of an inch of inflammation, whether the tendon is spared or swollen, changes the entire diagnosis.
It completely changes the patient's diagnosis and their entire treatment plan. Furthermore, myositis usually only affects one eye, and it causes acute, sharp pain.
And TED.
TED is typically in both eyes, symmetric, and the swelling itself is usually painless. That tiny geographical distinction on a scan is everything.
From the engine room, let's look at what is packing the rest of the space around it. The source divides this remaining area into the intraconal space, which is the stuffing inside the muscle cone, and the extraconal space, the shell on the outside.
Let's do the stuffing first.
Let's talk about the stuffing. It's full of fat and vessels and nerves.
And because it's so densely packed with blood vessels, Vascular malformations are common here. One of the most fascinating ones is the venous malformation, sometimes called an orbital varix.
What is that exactly?
These are essentially abnormal, tangled networks of veins sitting behind the eye.
The source mentioned something about holding your breath, making the eye bulge with this condition. That sounds incredibly intense. How does that work?
It's all about fluid dynamics. Because these abnormal veins in the eye socket are still connected to the rest of the body's venous system, they respond to internal body pressure.
Like blood pressure.
Yeah. If a patient with one of these tangles performs what's called the Valsalva maneuver, which simply means they hold their breath and bear down like they are trying to lift a heavy box, the pressure in their chest and venous system spikes.
And that pushes the blood upward.
Yes. This physically forces blood up into the tangled veins behind the eye.
And the eye literally physically bulges outward. Reversible proptosis.
Reversible proptosis.
And if you have the patient do this heavy lifting breathing maneuver while they are actively inside the CT scanner,
the lesion will visibly and dramatically inflate on the scan. The source shows a clear example where a lesion went from about half an inch to over an inch in diameter just by having the patient hold their breath and bear down.
That's wild.
It is a dynamic physical stress test that confirms the diagnosis right there on the screen.
Okay, moving outward to the extraconal space, which is the space between the muscle cone and the literal bones of the skull. The source talks a lot about something called the orbital septum here.
The orbital septum is a thin, fibrous sheet of tissue that acts as a literal biological shield. It extends from the rim of the skull bone down into the eyelids.
So it's like a wall.
Its primary job is to act as a firewall, keeping superficial, outside infections from getting deep into the actual eye socket.
Which brings us to the difference between a preseptal and a postseptal infection. Why does an emergency room doctor care so much about which side of the shield the infection is on?
Because the stakes are entirely different. A preseptal infection is in front of the shield. It's usually just a skin infection, maybe from a bug bite or a minor scrape on the eyelid.
Annoying, but not deadly.
Right. It causes a swollen red eye, but the eye itself and the brain are safe. A warm compress and some basic antibiotics usually fix it. A postseptal infection is when the bacteria is behind the shield.
And a deep infection like that usually doesn't come from a bug bite on the outside, right? It comes from the inside.
Most frequently, it's a dangerous infection spreading from the adjacent sinus cavities right through the bone. Because it's trapped deep in the space behind the eye, pressure builds rapidly.
Which threatens the nerves.
It can threaten the optic nerve, cause permanent vision loss, or even spread backward along the veins directly into the brain.
Wow. So they look at the scan to see where the infection is relative to that septum.
On a CT scan, the radiologist relies entirely on that thin geographical line of the septum to tell the ER doctors whether they are dealing with a simple bug bite or a life-threatening emergency requiring 5E antibiotics and surgery.
In that same outer space, the source contrasts two very different pediatric tumors, infantile hemangioma versus rhabdomyosarcoma.
Infantile hemangiomas are benign, and they are quite common. They are essentially disorganized tangles of rapidly growing blood vessels.
And they shrink on their own, right?
They have a very predictable life cycle. They grow quickly in the first few months of a baby's life, and then they naturally shrink and fade away over several years.
And on an MRI, because they are made of fast-moving blood, you see these empty-looking tubes. The blood is moving so fast, the scanner can't even catch the signal. They call them flow voids.
Exactly.
But how does that compare to the dangerous tumor?
We have to contrast that benign, naturally shrinking lesion with rhabdomyosarcoma. This is an aggressive, malignant pediatric tumor. It grows incredibly fast and can quickly destroy the surrounding bone.
How do they tell them apart?
To tell them apart, radiologists use that concept of restricted diffusion we talked about earlier.
Right, the trapped water molecules. Can you give us a good way to picture exactly why a tumor traps water?
Think of normal, healthy tissue, like a wide-open ballroom where people are dancing freely. Water molecules are the people. They can move around easily and spread out.
Okay, I can picture that.
Now imagine a highly malignant tumor like rhabdomyosarcoma. Because cancer grows out of control, it packs cells in as tightly as possible.
It fills the room.
Now that same ballroom is packed shoulder to shoulder with thousands of people. No one can move a muscle. That's what happens to the water. It's trapped by the dense wall of cancer cells.
Ah, so it can't flow.
On the MRI, that lack of movement is called restricted diffusion. It's a massive red flag, a hallmark of dense malignancy, which easily differentiates it from the benign, watery, free-flowing environment of a hemangioma.
Wow, that ballroom visual makes it so clear. It's all about how the tissue physically handles water and blood.
Okay, we're heading into our final neighborhood. We're moving to the upper outer corner of the eye, the lacrimal apparatus, basically the tear factory.
The lacrimal gland is responsible for producing tears, and most of the tumors that occur here happen in the larger, deeper portion of the gland tucked into the bone, the orbital lobe.
When a radiologist is looking at a tumor in the tear gland, how do they know if it's a slow, benign growth or a dangerous, fast-moving cancer, just from looking at a still image? The source has a really interesting take on this. They read the bone. That is the most reliable method. The adjacent bone tells the history of the tumor's growth over time.
So starting with the benign ones.
The most common benign tumor here is a pleomorphic adenoma. It's a slow-growing mass. It grows incredibly slowly over years and years. Because it grows so slowly, it doesn't destroy the hard bone next to it. It just gently and gradually pushes against it over time.
And the bone yields to it. The source calls this smooth bone scalloping. It just hollows out a smooth little bowl for itself.
Exactly right. But malignant tumors, like adenoid cystic carcinoma, don't respect those boundaries. They grow fast, and they are chemically aggressive.
So they don't just push.
When they hit the bone, they don't gently push it. They violently eat right through it. Radiologists see this on a scan as irregular, jagged bone erosion.
If we connect this to the bigger picture...
Wait, let me jump in here. If we connect this to the bigger picture, this raises an important question about how cancer actually moves through the body.
Right.
We usually think of cancer spreading through the bloodstream or the lymph nodes. But these specific malignant tumors in the tear gland have a terrifying propensity for what we call perineural spread.
Perineural meaning around the nerve. So they literally hijack the sensory nerves in the face.
They do. The tumor cells find the sensory nerves in the extraconal space and creep along them, using the nerve like a physical highway to travel deep into the face or back toward the brain.
That sounds incredibly painful.
It is. This is why patients with these specific tear gland malignancies often arrive at the doctor complaining of intense, excruciating pain around the eye, whereas the benign, slow-growing tumors are usually completely painless.
The tumor is physically traveling along the pain receptors themselves. That is chilling. But medically, it's an incredible piece of the diagnostic puzzle.
It's all mapped out.
So what does this all mean? We've covered tumors that look like tram tracks, muscles shaped like Coca-Cola bottles, peeling retinas that look like V-shapes, and choroids that look like tennis balls.
A lot of shapes today.
We've talked about holding your breath to make your eye bulge, and tumors that glow all by themselves because they are full of melanin. The major takeaway here, for you listening, is that the next time you get a swollen eye from a bug bite or a deep sinus infection, or you hear about someone getting an MRI, remember that the human body isn't just a random jumble of tissues.
Absolutely not.
It is a highly structured, intricately zoned map. Radiologists aren't just looking for ambiguous gray blobs on a screen. They're essentially highly trained cartographers. They are reading the borders, identifying the shapes, and watching the fluid dynamics in the ballroom to diagnose exactly what the problem is, simply by knowing where the problem lives.
If we connect this to the bigger picture, it truly validates the core philosophy of our source material today. Overwhelming information is only useful when it is structured. When you take a system as terrifyingly complex as the human orbit and break it down into these distinct anatomical compartments, the intraconal stuffing, the conal engine room, the extraconal shell, you transform impossible medical mysteries into solvable, highly logical puzzles. Location dictates the pathology.
It's a total paradigm shift in how we think about getting sick. And it leaves me with one final provocative thought.
Let's hear it.
As we discussed right at the beginning, this source material focuses heavily on how the optic nerve and its sheath are a direct physical extension of the central nervous system. The nerve is bathed in the exact same cerebrospinal fluid that surrounds your brain.
It is.
The eye is essentially the only part of the human brain that sits outside the skull, actively looking at the world.
That's a profound way to look at it.
If radiologists can map the microgeography of the eye's compartments with such incredible precision today, literally reading the trapped water molecules in a tumor or measuring the swelling of an individual muscle tendon, could we one day use this highly accessible window to diagnose systemic neurological diseases? Could mapping the fluid dynamics in the optic nerve sheath allow us to detect Alzheimer's or Parkinson's or other neurodegenerative diseases years or even decades before they ever cause enough damage to show up on a traditional brain scan?
That is the frontier.
It's definitely something to mull over the next time you look at yourself in the mirror. Thank you for joining us on this deep dive.